Thank you so much. It's such a pleasure being here, and it's such an honor to be included in such an esteemed group of surgeons and clinicians who've been bringing these topics to you all. It's so important for us to really share these moments and share the opportunity to see that metastatic breast cancer is more than just a bad word that you whisper. And what we have found is that there is life and there is thriving in the diagnosis. And hopefully we'll be able to learn a bit more about that together tonight. And then open up the questions for questions a little bit later. And so I'm going to share my content. And so for me, I think it's important that we have some goals for this. And at the conclusion of the presentation, I really want us to know more about the social determinants of health and biology that contribute to African-American breast cancer disparities. I want to identify how metastatic breast cancer affects breast cancer care, and then how patients with breast cancer should undergo multidisciplinary team approaches to care. Really closing the gap and discussing breast cancer in a way that patients understand and can make the best possible decisions are really my goal. When I think about metastatic breast cancer, it is something that is near and dear to my heart because I am actually a metastatic breast cancer patient. I was originally diagnosed in 2013 with an early stage breast cancer after undergoing chemotherapy. I underwent reconstruction, radiation, ultimately lost my reconstruction. And one of the things that I found out early in my course was not only that I had breast cancer in one breast, but I had breast cancer in both breasts. It's an unusual presentation, and being a woman who was premenopausal before age 40 when I was diagnosed, and ultimately having a 1.5-year-old baby, it was tough. It was tough to take on the diagnosis, but I knew that it was important. And I knew that the team that surrounded me, and that's not just my clinicians, but that was the team of people that were put in place, my family members, my friends who are closest family, and all of those who supported me through those moments. I went through treatment and ultimately came out on the other side, no worse for the wear. And then I fast forward to 2019, the beginning of the year. We had gone on vacation, and I kind of thought, maybe this back pain that I'm having is because I was lifting a lot of the luggage on the way back. But ultimately, in the back of my mind, I knew that this was a red flag, and so I went in for a CAT scan, and what we found was that I had metastatic disease. And for me, it meant the start of ongoing treatment that I knew wasn't going to stop. And for me, it meant also powwowing with my team and letting them know what are my goals for my care. And then ultimately coming up with a pathway that has led to a clinical trial that we found that actually worked for me and has reduced my disease down to less than a centimeter. So I am thankful and I'm blessed to be in a place where I can feel a bit more comfortable, but I'm glad that I have the ability to come before you and talk a little bit about metastatic breast cancer, because really closing that gap is what this is all about. Just as a bit of a background, so if you all weren't on some of the other webinars, it's important for us to be grounded in information. So when we estimate the number of breast cancers in 2020, what we're really talking about is more than 275,000 women about 30% of female breast of cancer, about 30% of cancers in females is breast cancer. And then when we think about breast cancers for those that succumb to the disease, it's about 42,000 that are going to be counted this year. But it's important for me to really then ground myself in what it's like to be a Black woman with breast cancer in these days and times. I have to think about the strides that have been made from the time that a very close relative of mine was diagnosed when she was in her 30s to the opportunities that I actually have now. There are about 33,840 breast cancer Black patients in the that will be diagnosed. And that's about 32% of cancers for females who happen to be of Black ancestry. When we think of where it happens, the location for non-Hispanic Blacks, we see that the vast majority of our population of patients and people of color are really in the mid-Atlantic to the south. And it's important for us to also know that when we look at these numbers, how things have changed. When we look at 1975 to 2015, what we've seen is there's been a difference between the incidence or the number of Black and white breast cancers. It used to be that the incidence was greater for white women. What we've seen in the left graph is that it has come together. And what we also see is that mortality is still, and it remains higher for Black women as the curve for white women continues to drop. We have to be cognizant of how it impacts our community, because we know for Black and African American women that race and ethnicity makes a difference in mortality when we talk about breast cancer. And why is it important? It's important because we know that Black women could succumb to disease more frequently than Caucasian women. We know that statistically, Black women are often diagnosed when treatments are limited, costly, and the prognosis is poor, and are often diagnosed younger and with more aggressive breast cancers. This is the time to now take a deep breath. These are the statistics that are difficult for me to share, but the important part about this is that when we think about breast cancer and we think about metastatic breast cancer, we have to think about it in different terms. It's important for us to know the types of breast cancers. When we look at breast cancers can be localized just to the duct, localized to the breast. It can go from the breast to the lymph nodes underneath the arm. And then for patients like myself, it can go to other places in the body. When we think about types of breast cancers and subtypes, I think it's also important for us to look at the right graph. The right graph really, the darkest gray are the triple negative breast cancers. When we look at the second graph from the left, what we see is about 21% of breast cancers are going to be triple negative breast cancers, and the vast majority of those are going to be Black women. And when we think about those, they're more likely to go on to metastatic disease. So what is metastatic disease exactly? What is metastatic breast cancer? Metastatic breast cancer means the cancer has spread from the breast to distant organs. And no matter where the cancer spreads, it's called breast cancer or metastatic breast cancer. The most common places that we see that it goes is to the bones, to the lungs, to the liver, and to the brain. How common is it? About 155,000 women in the United States live with metastatic breast cancer. So there is a large number and a large community of metastatic breast cancer patients. Men can have metastatic breast cancer too, but their numbers are so much smaller than our women. However, it does occur, and it's important to know. Another statistic that's important to know is that 20 to 30% of women who are diagnosed with an early stage breast cancer will later spread to stage 4 or metastatic breast cancer. And stage 4 is the most advanced stage of the disease. It can happen at any age. However, what we see is that it happens in patients oftentimes who are diagnosed with more aggressive diseases and later stages. 6 to 10% of women with breast cancer are diagnosed starting at stage 4. And a third of the breast cancers that we discussed tonight will progress to stage 4. Metastasized is another way of saying spread. And metastatic breast cancer, I think above all things, we need to know that it is lifelong, but it is treatable. Where do our cancer symptoms come from? The symptoms vary, but when we think about what happens in our bones, when the metastasis goes to our bones, most commonly you have a sudden noticeable new bone pain. You most often may feel this in the ribs, in the spine, in the pelvis, in the long bones. I felt mine in my back, and I noticed that it was persistent, and that is an important part as well. Other places, lung metastasis, you can have chest pain, shortness of breath, or persistent cough. Brain metastasis may include headache, changes in speech or vision, memory loss. Liver metastasis, and remember the liver is on the right upper part of your abdomen. You may have pain or discomfort of your midsection. You can have fatigue, weakness, weight loss, poor appetite, jaundice, which is yellowing of the eyes, or fever. And remember, there is a spectrum of symptoms, and that's oftentimes not where you start. What is it is important to know is that there are many determinants of health, and it's important for us to know that the wellness in our community isn't just one thing. It's not just economic. It's not just access to care. It's many other things as well. It's having our economic stability, making sure that our medical bills can be paid and that we have support in that aspect. That our neighborhoods and physical environments, our housing, transportation, our safety, our playgrounds are all working toward our good. Education, that literacy is an important part, knowing our body, knowing what to look for, and coming to events like this so that we are the most educated that we can be about what's the changes there are to look for. Access to healthy foods, making sure that our social interactions are positive, our community engagement is positive, and then our healthcare systems are not discriminating in our care and provide our opportunities to be equitable. This really shows us the impact of access. The more that we see that communities are able to access high quality care, the better the survival and the lesser is the survival disparity. We think about opportunities for treatment. When we think about early stage breast cancer, we oftentimes think about breast conservation, keeping the breast in place, and undergoing surgery that will keep the breast intact. And that happens in about 75% of patients. In about 25% of patients, we have patients who come to us with increased risk, or have a tumor that is large enough that we can't leave the breast behind. And that happens in about 25% of patients. And what we find is that mastectomy is a part of and parcel of care. But these are just background information. What we know when we think about breast cancer that is metastatic, we're really trying to treat that breast cancer so that we are taking care of ourselves. We are in the best possible environment. We have put together the social network, and then ultimately the team that is going to listen to us and be our advocates. And in that, identifying what type of care is going to be important for you. What are your goals in care? What do you need to know to be your healthiest and to live your best life? And what we need to know is that oftentimes this means more treatment, and that means chemotherapy, medications that are either given orally or given through an IV, targeted therapies that work within the cancer cell to break open the cancer cell and then ultimately allow it to be modified by many other techniques. Christian! Immunotherapy, using our own body to fight off these cancer cells, has been one of the most useful technologic advances that have been looked at along with targeted therapy to increase the ability to improve survival and lengthen the time that patients are in either low amounts of tumor and more stable, because that really is our goal. And are there additional treatments that are important? Hormonal therapy is one of the standards. If your tumor is hormonally receptor positive, we oftentimes use a blocker to make sure that we can keep that in place. Looking at the molecular level of your breast cancer and its expression, and seeing that next generation sequencing is an important part of finding out what are your specific targets and how can it be tailored to you. And then I can't say enough that complementary and holistic medicine, looking at our whole bodies and making sure that we are putting things in place to have the healthiest lifestyles, and whether that is acupuncture or Reiki therapy or many of the other holistic approaches to making sure that we are cared for, it is an important part of what we do. And then I cannot advocate strongly enough for the thoughts of what clinical trials play, how they play a role in our treatments, and making sure that you are aware what clinical trials are available for you, and making sure that your team keeps you updated on that as well. Whether it is radiation therapy to treat recurrent bone mets, or whether it's precision medicine and using these technologies to personalize your care, knowing the clinical features, knowing the things that are specific to your tumor so that we can target your care specifically. And so the knowledge of all of our options are important. Knowing what our barriers are and what our strategies. I think that the value of a multi-team approach cannot be overemphasized. It is important to have more team members that are advocating for your health, advocating for your well-being, knowing the expert areas that are going to improve your quality of life, as well as improve the quality of your care. And this team really should be expansive. You know, you start off with your surgical oncologist and your breast surgeon, potentially your plastic and reconstruction surgeon, maybe, but your medical oncologist in your metastatic team is going to be an important person to be able to manage what your care is and helping you make those partner decisions to what the next step should be. As I said, radiation oncology, I underwent radiation for my early bone disease, and it has been helpful in managing my care and taking care of the disease that I had and has made it dormant. Our pathologists who help us to really understand what types of cells are making up our particular breast cancers and our metastatic diseases. Our radiologists, our nurse navigators, our oncology nurses, our genetic medical geneticists, our social workers, our translational researchers, and for me, pastoral care is a major part of what we do. And so in the bigger picture, it is going to take all of us. One of the important things that I've had an opportunity to do was to present at the White House when President Obama was in office. And one of the astute things that he came up with was the Precision Medicine Initiative. And it really was about enrolling 1 million patients in the United States to get an idea of how diseases impact the United States in lifestyle, environment, and in biology. And so it is one of the techniques that I think is useful in research to know more about how do we best manage the individual and ultimately use that to save lives. You know, I think in the bigger picture, you know, the mantra is always that mammography is key, mammography saves lives. But what we know is that knowledge is power. Knowledge saves lives. We are able to better manage who we are and what we need to do as metastatic breast cancer patients when we know the options that there are for us. We have the right team in place. We have the right opportunities for care, and it is done equitably and allows us all to live in those social determinants at the highest level with the greatest quality of care. Thank you.
Awesome. Thank you so much, Dr. Wilson. So now is the good part where we get into the questions. So let's see what questions we have. You really shared some great nuggets for us tonight. So I'm going to go into the Q&A, and if anyone's on the chat have additional questions, feel free to post them in our Q&A chat. So one of the questions is, my cancer came back in the lymph nodes almost 5 years later in the supraclavicle area. Why is it that that's never listed in the metastatic areas when it comes to cancer? Isn't that considered metastatic in stage 4?
And that's a really great question. I think that it is oftentimes, as a clinician, I see that because the staging levels that are utilized for us actually has that as a clinician. The more detailed staging protocols that we use for staging our patients, yes, it has the supraclavicular lymph nodes, and they are thought to be outside of the breast, so outside of that local regional area of the breast, the underarm, and so it is a more advanced stage. It oftentimes isn't used because it's a small percentage. And oftentimes it gets confused with the lymph nodes underneath the arm versus the lymph nodes above the collarbone in the supraclavicular region. But that's a really astute question. Thank you. I've never had that question before, but I will now make a point in my office visit to point out the difference between axillary lymph nodes, the ones that are considered regional, and supraclavicular lymph nodes, the ones that are thought to be outside of that region.
Thank you. So since we're talking about Black breast cancer tonight, you know, triple negative is one of the ones that you mentioned that Black women are more likely diagnosed with triple negative, and we know that that's a little bit more aggressive. So can you explain why are we more likely to be diagnosed with triple negative breast cancer?
So, you know, there are lots of theories, and I just want to, and this is actually one of the reasons why I put up the slide that I did. Remember that in the presentation, 21% of the patients were triple negative. So the vast majority of Black women actually present with hormone receptor positive breast cancer. However, larger percentages of all breast cancers happen in triple negative breast cancers who happen to be Black women. Let me say that one more time.
There you go.
When we have, when we look at all breast cancers, 21% of the breast cancers are going to be triple negative. That's not the majority. The majority is going to be hormone receptor positive. But in the group that actually is triple negative, there are larger groups of Black women in that. And why is that the case? We think that there's probably some ancestral things that are going on. We think that there's probably some additional genetic things that are going on that we've not been able to identify yet. It's one of the important reasons why we need to be part of clinical trials, why we need to be part of, and not even treatment clinical trials, but clinical trials like the one I put up, all in one, for us to know more about what is specific to our population of breast patients who happen to be Black and happen to be triple negative. When we have larger groups that we can study, then we know more. When we think about studies that look at breast cancer, less than 5% of women in those studies are Black. And so we can't really say what's normal for us because we don't have enough to really study. And so the studies need to be done. We're really in a place where I think that we're going to, in the next 3 to 5 years, we're going to have tremendous work from many of the companies who are supporting this, these talks, and companies that are going to expand our knowledge about the molecular and genetic aspects of breast cancer.
So if we're saying triple negative is one of the most aggressive forms, then what about triple positive? Does that mean that it's just easier to treat? And why is that?
And so triple positive means that you have several other targets that you can access to treat. When you have triple negative, there are 3 proteins or 3 elements of a cancer cell that are important: the estrogen receptor, the progesterone receptor, and HER2. When none of those things are present, then we have nothing to target. And the only means that we have is a generalized chemotherapy. When you have estrogen receptors present, you have HER2 present, then you have your chemotherapy, plus you have 2 additional targets to reduce the risk of breast cancer. And so it's not that it is just an easier to treat, but we have more targets to treat. And more targets to treat means that you have better opportunities for survival.
So when looking at triple negative breast cancer, you know, doctors sometimes will give patients an option, whether it's the infusion or some type of pill, you know, after radiation or what have you. So what would be like a better choice, or can you explain the difference between getting the pill or getting an infusion, especially for those who may have, you know, ailments like COPD or some kind of comorbidities? So, you know, what does that look like? How can we address that?
So let's think about chemotherapy as being equal to the word soup. Chemotherapies are, when we think about soup, there are different types of soup, right? You have bean soup, you have chicken noodle soup, you have all of these different types. So chemotherapies, there are different types of chemotherapies that go into treatment of triple negative or metastatic breast cancers. Each and every one of those medications has a profile of its patients that it's best used in, or it cannot be used in. And some of those things may impact the heart. So we can't use it in someone who may have a heart condition like congestive heart failure. It may impact the lungs, so we can't use it in patients who have COPD. So it really is about tailoring what your history, what your medication profile is, because we don't want anything that's going to conflict with your normal everyday medications as well. And then you are going to also make sure that the medication is going to be shown to have the highest improvement in patients. There are definitely medications that are thought to be first line, which means it's the first medication. It's been studied the most. It's shown to have the most impact on patients and to have the best outcome for patients. When that is no longer working, then we usually think of second line medications, which is probably a different set of chemotherapies or pill form that is used to treat, and it's something that the body usually hasn't seen before. And then when that stops working, then we use something else. So really the pill and the chemotherapy is really dependent upon in your individual health profile, your individual characteristics of your cancer, and what types of things you're trying to accomplish with your chemotherapy.
Thank you. So let's change up a little bit. So we talked a little bit about the drugs that patients will typically take and get prescribed to them. But let's talk about screenings or kind of the follow-up to see where a patient is when it comes to metastasis. There's all types of scans. There's your MRIs, there's your PET scans, there's your CT scans. Can you talk about the difference in all of the different scans and what that looks like for the patient? What are they looking for in each one of those particular scans?
I think that's a really great question. When we think about the scans after your treatment, remember each person's treatment should be tailored. So you may not have the same scans as your friend may have. It is really determined by your initial staging. That's what size was your tumor? How many nodes were involved? Is there any distant disease? Once that is determined, then we then know how to follow you. There are some standard guidelines that we usually follow in patients. We usually see patients after their diagnosis and their initial treatment after they're done. Usually every 3 months for the first 2 years, then every 6 months for the 2 years after that, and then at least once a year. What we're really looking for, honestly, is are there any signs or symptoms of progression of disease? A good physical exam is where you start to make sure that if the breasts are in place, that there's no new findings in the breast tissue or in a reconstructed flap. You also want to make sure that you are, once that examination is done, that you also will check the lymph nodes above the collarbone, in the neck, underneath the arm, and the exam should also be exam of the abdomen and of the liver, which is the right upper quadrant of the abdomen. Because remember, those are the sites where we most commonly see progression, or we see spread, or we see metastasis. So when I see a patient, I want to know, how is your vision? Are you having any headaches? Are you noticing any memory loss? Are you having any nausea? Are you having any belly pain? Have you noticed any change in the color of your eyes? Have you any new cough? Do you have any new shortness of breath? Do you have any new bone pain or pain that you can take one finger and you can point to and it's there all the time? Those are the signs for us to then add some additional studies. And those are for early stage breast cancers that go on to, that we are trying to identify progression. For those patients who are later stage or metastatic, then we have a different plan for those patients. We're more concerned about them progressing because of the later stage that they came to us. And so oftentimes you will undergo a PET scan, which is a scan that looks at the entire body and gives us an idea if there's any special absorption in any particular area of the body that will show us whether there's metastasis. You can always also look on a CAT scan of the chest, abdomen, and pelvis. And usually they'll give you dye that will light up your blood vessels as well as your lungs to see if there's any area of spread. If you have a headache, then an MRI of your brain is going to be important. And then oftentimes, if you're in a higher risk group, then an MRI of the breast is going to be useful because MRIs of the breast will show the breast in so much more detail than what mammography does. It will help us follow any changes and also helps us identify any areas that are different before they can even be felt.
So you brought up a really good point. You talked about the different types of scans and when they're actually used, whether the cancer is already metastasized and you're trying to see, is there any further spread? One of the things for early stagers, oftentimes their doctors really don't have the conversation with them about what to look for or what are some of the symptoms that may be a sign of the cancer has come back or it may have metastasized or what have you. So what would those things be? I mean, we know that cancer, especially in Black women, we're more likely to have a recurrence. So what are some of those signs and some of those symptoms that patients should be looking for? Because oftentimes we may feel something and we just kind of ignore it and think, oh, this is my new norm, when it may not necessarily be a new norm. It could be something else happening. Can you speak to that?
Of course. I think that one of the key elements that sort of was very subtle in the presentation is having a team that you feel comfortable and confident in, because it is important that anything that's new and persistent needs to be brought up to your provider. So the things that we're looking for are new pain, new changes in skin, new changes in lymph nodes, new changes in the overall body. So let's think about what that means. So our lymph nodes, we know, are in our armpits underneath our arm. And those are the ones that for early stage are most connected to the breast. We want to feel those and make sure that there's no lumpy bumpiness or tenderness in either an armpit that's new. Sometimes we can nick our skin and get a little bit of infection and those lymph nodes will be sore, but they should not be sore for an extended period of time. They should not be large for an extended period of time. If they are, bring it to the attention of your provider. I always say, I want to see you back in 3 months. However, if there is something new or different, I need to see you back as soon as you notice that. And that is the mentality we have to have, that we are not bothering our clinicians. We are not doing anything other than making sure that we are in our best care. And we are doing the things that we know that are important. So if you have an ache that is new, you never had that ache before, like I said, you can use one finger and you can point to it and it's there every day for at least 2 weeks. You need to see your doctor about that. If you have difficulty sort of standing up because, you got this ache in your back, that, someone say, well, that's just arthritis. That's not, but you never had that before. You need to take that to your provider. If you have skin changes, you notice that the skin has a little, a sore. The skin may have a lump when you raise your arms. I'm a big proponent of examining yourself, making sure that you know what's going on with you. So I usually tell my patients, stand in front of the mirror and raise your arms, and then put them on your hips and do your Superman woman pose, and, push in. That is going to accentuate this part of your body. So if you can see something that's new or different, a new lump, a new change in your skin, there's a little darkening in the skin, you need to bring that to the attention of your provider. It is important to put yourself first when it comes to feeling what should be right or wrong. It's not your job to diagnose yourself. It is your job to just bring new things to your clinician's attention.
Yeah, and you brought up a good point. It goes back to the patient-provider relationship, you know? So I think that was a really good thing that you brought up. So let's talk about HER2. When we look at HER2, we've heard about triple negative, but are there a lot of options around HER2? And is that something pretty common, HER2 positive?
So it's not common. It was actually one of the smaller little blocks that we saw on that graph. It is targeted. There are actually more medications now that are targeted to HER2. We used to only have one that was Herceptin. We have pertuzumab, and we have others that are coming out. The goal of those medications are to block that from being stimulated. And so blocking the HER2 is another way of treating the breast cancer and making sure that we try to stop it in its tracks and keep it from microscopically dividing and spreading on levels that we don't see before we can see it. I think one of the things that's really difficult with metastatic, and it's always been a difficult thing for me, is that we don't honestly have a good bridge between the diagnosis and then a recurrence. There are some tests out there that people use, but it's not really standard to use those tests because they don't do an excellent job in identifying whether you've recurred or not. So that's a big gap that is really left up to the patient to decide, well, when is this pain that I'm having enough for me to bring it to my clinician? Or when is this cough that I'm having not bronchitis and something that I should bring to my medical oncologist or my surgeon? Or when is this pain that I'm having in my neck or my back, something that I need to stop taking this Motrin for and take it to my doctor? We unfortunately don't, I think, prepare that gap as well for our patients, nor do we prepare it as well for our primary care partners. And there is a real gap in identifying a marker that can be something that is really a solid marker for us to go to, and it be a quality marker that's going to tell us when something is in its early stages of coming back.
Let's talk about herbs and supplements.
Sure.
Using that to complement conventional treatments. A lot of times the doctors don't want you to use any of those supplements, and they're pretty, adamant, like, we really don't want you to use any kind of vitamins or what have you. Can you speak to that? Why is that the case? And if there's anything that they could take that wouldn't counteract anything that they're already taking? In terms of chemo.
I know. It is tough because the clinician is always looking out for the best possible outcome from the treatments that they're trying to give. And I can absolutely appreciate that. What we know is that there are definitely practices out there that work with naturopaths and work very comfortably with complementary medicine experts, and they work together to put together a plan. That may be one of the questions, if holistic medicine is one of the things that you want as part of your care. That might be part of the process of finding your team, finding that team that actually works well with complementary medicine. It's hard for me to not advocate for complementary and holistic medicine, because I've seen the benefit it has in both my patients here and when I was at the University of Connecticut. I was in charge of a group of naturopaths that worked in our oncology unit. And we used acupuncture as well as Reiki, and we used complementary medicine for symptom relief. And what we found is that patients actually had some really very great collaborations with our naturopaths and our holistic medicine, complementary medicine experts. I know I've talked around it because it's really difficult to get some clinician to break out of what they're comfortable with. But it's important. If it's important to you, it should be important to your clinician. And if you are working before you start, if you're looking for a team and that's important to you, make sure that your team uses that. There are lots of really great practices all across the country that uses complementary medicine.
This is a really good question. It kind of somewhat ties a little bit into what we're talking about. So this kind of goes back to the PET scans. And if there is a PET scan that's being done and there's, you know, very little metastatic disease left or no evidence of disease, should they, you know, someone who's metastatic, should they actually stop their treatment or change the treatment that they're on?
So what we know is that currently metastatic treatment usually means that there can be times where there is remission, where it's the cancer is controlled, and there may be times where the cancer is growing. The important part is to stay on top of knowing where you are in the process. It is a important individualized discussion about whether you should pull back on your treatment or not. And whether treatment is ongoing for you. That is an individualized question that each patient who's metastatic needs to have. There are patients, like for instance, my treatment, I would never stop. My treatment I know is going to be lifelong. There are other patients that they only have a small amount of disease, and their disease is very receptive to treatment, and will stay in remission and can be followed for long periods of time before you see an increase in tumor. So that's why I say it's very individualized. You have to understand how aggressive is your tumor, how indolent is your tumor, or how can it be treated, and just stay in its place with follow-up scans to show in a short enough interval that that you can ultimately stop or start your treatment. But everyone cannot stop treatment. Treatment, oftentimes in metastatic like cancer patients, for some patients, like I said myself, is gonna always be there. I know that if I stop my treatment, my disease likely is going to double more quickly.
And Dr. Wilson, we have so many questions, so we're getting close to our time. So I'm going to ask you this last question, and I think this will be pretty helpful because we talk a lot about information that's all out on the internet. There's so much information that's out there, and you know, one of the big things that I know LBBC talks about is trusted sources. And there are two questions, but I'm going to pull them all together. So this is around detoxing after chemo. And this is also talking about like the intermittent fasting, trying to kind of fast either before you start chemo or any kind of targeted therapy to help reduce the side effects and toxicity. So what would you say, because there's studies out there about that, but what would you say about that? Again, we want to make sure that it's coming from a trusted source.
You know, I think that it's important for us to understand very clearly what our medications are, what are the expected potential side effects, how frequently do you see those side effects, and when they happen, what is the impact of those side effects, and what is the quality of life that goes along with that. I think it's important to really know and understand that health is paramount to all of these things. You have to be in a healthy state of mind. You should be in a healthy state of body. And for detoxing, that's a big word to me, because every detox is not the same. Your detox needs to be something that you discuss with your provider, because one of the things you want to make sure of is that you're not dehydrating yourself, that your nutrition remains stable, and you're not taking any nutrients that your body needs to repair itself while it's fighting the cancer. We know that detox may mean that you are taking all of the nutrients away for long periods of time with just small supplements, or it may mean that you're using a very health directed tonic that actually has many of the nutrients in it. We also have to be thoughtful that when we're looking for these things, I am a big proponent of making sure we're not taking away from our health. We need to make sure that the nutrients, our vegetables, our fruits, our protein sources are all there, because those are necessary for us to be healthy.